So today we will discuss about rectum. So as all of you know, it is the termination of sigmoid colon, and it begins at the level of sacral promontory and ends at the anorectal junction. So here you have an important muscle called as tuborectalis, which encircles the posterior and lateral aspects of the anorectal junction, forming an important angle. This maintenance of this angle at 120 degrees is very important because of the function of the rectum as storage or ampulla. Then, as you know, the teneocoli of the sigmoid will form the outer longitudinal muscle of the rectum. And as you know, the rectum is not having serosa. So, mucosa muscularis, submucosa and muscularis. So, there are three curvatures. The upper, lower convex towards the right, whereas the middle convex to the left. These are marked by what are called as Hurston's valves or semicircular folds of Hurston. So this is the anatomy. So this is the rectal ampulla. So this is the rectosigmoid junction from where the rectum extends like this up to anorectal junction. And you have right side two convexities. These are the two convexities on the right side, and this is the middle convexity to the left side. And you can see the semicircular folds. These are the semicircular folds of Hurston. So fairly large volume structure, as you can see, compared to anal canal. And so there is another halo, that is the rectal, that is sacral halo. So that is the major curvature of the rectum. So if you see the lateral view, you can see that this is the sacral halo in which the rectum will exactly fit in. As you can see in this diagram, it is ending at the anorectal junction, and this is the puborectalis muscle, which is encircling only posteriorly and to some extent laterally, but not anterior, as you can see. And this is the angulation. See, this is the angulation. Here also it is seen. This is the angulation about 120 degrees. So you can also see the volume of the rectum here compared to anal canal. And this is the other view, as you can see. And here you can see that the peritoneum is covering not completely, only part of the rectum, upper part, upper 1/3 of the rectum. So adult rectum is approximately 15 centimeters in length. This is very, very important. All of you should remember this figure. Like already I told you about esophagus, duodenum, ureter, they are 25, whereas the oral cavity to the esophageal junction is 15 centimeters. Here also the rectum is 15 centimeters. And it is divided into three equal parts. So upper 1/3, which is covered entirely by the peritoneum, mainly on the anterior and lateral aspects. And the middle 1/3 covers only and part of lateral, that is middle 1/3, whereas lower 1/3 is completely below the peritoneum. So This is how these are important for the lesions, surgical lesions of the rectum. So another important aspect of this rectum is the fascia, which are around the rectum. So the lower third of the rectum is separated because it is below the peritoneum. It is separated from either prostate in males or vagina in females anteriorly by the Denon-Villiers fascia. Whereas the lower sacrum and coccyx, it is the Waldeyer's fascia. This Waldeyer's fascia is anterior to the presacral fascia. I will show you that also. What is the surgical importance? They act as barriers to malignant lesions. So if any carcinoma of the rectum is there, if you can remove these layers, so that means you are sure that there is no recurrence. If you traverse these fascia, that means you have compromised and there is chance of recurrence. So this fact is what I have given here. So anatomical envelope of total mesorectal. So this whole thing is called as mesorectal complex. So they will act as envelope. So if you can remove along with the envelope, that is called as total mesorectal excision, TME, for complete oncological clearance. So this is very, very important. So these are the layers, as I told you. So this is the bladder and prostate in a male, where you can see that this fascia is there. So you should not go between the rectum and this fascia. This whole fascia should be removed so that you are oncologically complete. So this is the Denon-Villiers fascia, which is just deeper to the peritoneum. So this is the peritoneum. So this is the rectovesical pouch in males, whereas in females, as you know, there will be rectovaginal pouch of Douglas. So like this. So this is the rectovesical pouch, below which is the Waldeyer's fascia. So while removing the rectum, you have to open this peritoneum and then remove along with this whole Waldeyer's fascia. Similarly, if you go back, you can see that this is the rectal fascia and this is the mesorectum with lymphatics. So you can see here, these are the, so you are supposed to remove up to this, but don't touch this. This is the presacral fascia. So you can see there are so many vessels here. If you, by mistake, if you open this, you are doomed. So because a lot of bleeding will occur. So you are not supposed to open this layer. That's why the artist has also drawn very nicely, as you can see. So this is the Waldeyer's fascia, and you are supposed to open like this in this cleavage. Okay. So this is the Waldeyer's fascia, right? So you are not supposed to open here also. If you open here means all these lymphatics, everything, this entire mesorectum gets opened and then tumor cells can traverse this area and then recurrence is the chance. So that's why this layer and this layer you are supposed to remove along with the specimen. Then only it is complete oncological clearance. Okay. So now what is the blood supply? So the blood supply is the inferior mesenteric artery will continue as superior rectal artery. So here don't get confused. It is inferior mesenteric but superior rectal artery. So this is single artery. Okay. Whereas the next two are double arteries. That is the middle rectal, which is a branch of internal iliac, and inferior rectal, which is a branch of internal pudendal artery. So these are uh, twins, whereas this is only single artery, superior rectal artery, which is a major branch of major blood supply to the rectum. Okay. The lymphatic drainage, of course, follows the blood supply, and the drainage is upwards. This is very, very important for, again, oncological. So, whenever you are doing resection of the rectum, then you are supposed to clear the superior lymph nodes. So, at the root of inferior mesenteric artery, you have to go up to that. So, of course, the other thing, fact is, embryologically, rectum is two parts. One developing from hindgut, that forms the upper rectum, whereas the lower is divided from the cloaca, which will again divide into the anorectal and this rectovaginal pouch will be formed there, and urorectal and genital will be separate. So now let us go to the symptoms of the rectum disease. So most important, all of you know, is the bleeding. That bleeding is fresh bleeding. So bright red blood. If the patient is complaining, it is from anorectum. So very important symptom. Even in carcinoma, this is the commonest symptom, bleeding per rectum. Just like in kidney, bleeding, hematuria. Here also, bleeding per rectum is very important. Okay. Another thing is just like colon, altered bowel habits. Sometimes constipation, sometimes diarrhea. So this is the next important symptom. Then of course, mucus discharge. This mucus discharge we should not take lightly because sometimes there may be obstruction, and because of the irritation with the contents, the mucosa of the rectum will secrete lot of mucus, and that is discharged. So don't take lightly this mucus discharge. Then tenesmus. So tenesmus is a peculiar symptom wherein the patient gets an urge to defecate, but he or she cannot because of either pain or obstruction. Only few drops of blood can that's all he will, either mucus or few drops of blood he will discharge. So that is very important. So, do you know any urological symptom that is similar to tenesmus? I have asked this question, I believe, earlier. What is that urological system? Now that you are perfect in urology, yesterday only urology last class was over. So, you should be knowing the urological symptom that is similar to tenesmus. So, nobody yet. So, if you remember the symptoms of urology, that is very important chapter. All of you should be thorough. Of course, hematuria is very important, but other symptoms are, if not equal, at least they are good. Yeah, very good. Strangulary 4826 no, 4826, you are correct. So it is strangulary. So strangulary and tenesmus, these two symptoms are peculiarly present. Patient will have urge to pass, but they may not. So that is tenesmus. And of course, prolapse is self-explanatory, just like prolapse uterus. The rectum can also prolapse. Then proctalgia. So some patients, particularly those who are having psychological problems, they may have what is called as proctalgia, intense pain, or otherwise called as proctodynia, similar to coccydynia. So proctalgia. These are the symptoms of rectal disease, but most important being the fresh bleeding. Okay. Now, how do we examine the rectum? So the external examination before doing proctoscopy, you are supposed to inspect. Of course, not many lesions of rectum can be seen outside, but two important lesions of the GITs. One is interception. If it is below per annum, it can present very, very rarely. The other lesion is the prolapse rectum, which you can see apart from the lesions of the anal canal. What are the lesions? These are the two lesions of the GIT. One is the interception. The second one is the prolapse rectum, which you can see by inspecting the perineum. Then digital examination is the most important aspect. So very, very important in mainly for carcinoma of the rectum. There is an old saying in medicine that if you don't put your finger in the rectum, you will put your foot in it. So very, very important. So you have to examine digitally, because that's how you can diagnose carcinoma of the rectum, because it is accessible per rectum, per this anal canal. Then of course proctoscopy, another important thing. So you will visualize with the proctoscope, which is the one with, it may be self-illuminated also. And nowadays we are getting disposable proctoscopes. Usually we have metal proctoscopes, but digital also are coming, and self-illuminating are also coming. Otherwise, with the available proctoscopes, we have to arrange for lighting also. So proctoscopes, you can visualize all lesions of not only anal canal, middle and lower rectal lesions also can be nicely seen with the proctoscope. Maybe rectal polyp, maybe carcinoma of the rectum. Then of course, sigmoidoscopy, whenever you suspect a lesion higher above upper rectum or in the colon, sigmoid colon, then you can do sigmoidoscopy. Of late, less and less rigid sigmoidoscope, mainly flexible sigmoidoscope, just like colonoscope, which is longer because it has to go up to cecum or even terminal ileum. So that is longer one, whereas that is more than 1.5 meters, whereas this is less than that, 75 cm. So this is how you have to put your finger, various positions, all of you know. The three positions which we adopt for per rectal examination, what are they? Can I know from you? Three positions. Yes. What are the positions? Yeah. All of you are left lateral. So all of you are telling left lateral. Only 7437 So you have said knee elbow. One person says posterior, I don't know what it is. And 6-3 says lithotomy. So all are covered now. So in females, usual position which we put is so on the back. That means lying down. So lithotomy. Lithotomy means like this. Okay. So back here. Then this is the position which we mainly use for females, that is Sims position. So it is left lateral. So of course the right leg should be flexed, left leg should be straight. So like this, so like that. Then you have knee elbow. Wherein it is like this. Okay. So all these positions we can adapt. So the first one is for lithotomy, which is mainly we use for surgery. So lithotomy is for surgery. Sims position for ladies. Knee elbow position for males. Okay, and you can introduce your finger, a well lubricated finger. Before that, at least oral consent you have to take. And what you are going to do also, you are supposed to tell the patient that you are introducing your finger. It's a gloved finger, as you can see. And then you have to gradually go. Otherwise, you are supposed to introduce finger flat of the finger, not like this, gradually, like this, you can go, not like this. And then another thing is, as I told you already, in a step way. So from proximal or distal to proximal, you are supposed to go and then feel all the structures. So both intraluminal, intramural and extramural. Extramural in males it is prostate, whereas in females it is the cervix and the rectovaginal pouch, which you will feel. And then intramural, mainly carcinoma of the rectum and polyps. And you will not feel piles peculiarly. Then, of course, in the lumen, if there are any foreign bodies, you can feel. So this is the sigmoidoscope, this is flexible sigmoidoscope. Now, let us go to the lesions. Of course, congenital problems we will discuss in anal canal. So, injuries. What are the injuries? Of course, road traffic accidents. There may be injury to the rectum. And you have to divide them into two. Is it above the peritoneal reflection, that is intraperitoneal, or is it below the peritoneal reflection? Of course, the treatment differs for both of them, but for both of them, you are supposed to do colostomy. Defunctioning, it is called as defunctioning colostomy, because you are directing the fecal matter away from the site of injury so that the site of injury will get healed rapidly. Otherwise, not only the site of injury gets infected, there is another serious risk of associated necrotizing fasciitis of the entire layers from outside to inside. So, very, very important that you do a diverting temporary colostomy. Then, if it is intraperitoneal, what do you do is open the abdomen and then close the perforation and then give peritoneal toilet and then close. Whereas if it is extra peritoneal, that is below the reflection, you need not open the abdomen except for colostomy. What you do is wide drainage is important so that the discharge or pus will be drained away from the site of injury. Of course, antibiotics are mandatory. Not only the antibiotic anti-anaerobics like the metronidazole, for any bottom surgery, in addition to broad spectrum antibiotics, you are supposed to give this metronidazole. Very, very important. Then another important thing is associated bladder and urethral damage, because as you can see, the proximity of the bladder and the prostate with the rectum. So this is the rectum here. So it's that you have to be careful about. And urethra also, as you can see, urethra, right? Now let us go to another lesion, that is the prolapse rectum. So the prolapse rectum is of two types. One is mucosal prolapse. Only mucosa and to some extent submucosa may protrude. Actually, strictly speaking, it is only protrusion, not exact prolapse. Whereas the other one is full thickness or complete. That is also called as, just like uterus, this is also called as prosidentia. So now let us go one by one. So mucosal prolapse, mucosa and submucosa, but there is a limit for it. Only maximum is 4 centimeters. It may be from 1 to 4. If it is more than 4 centimeters, then it is complete prolapse, all layers. Okay. So usually mucosal prolapse is less than 4 centimeters. And in infants, it can be common because the sacral curve is not yet well developed. It's almost straight, the sacrum. So that's why there may be mucosal prolapse. Children after diarrhea or due to some cause, they have lost weight. So there is no support. So loss of fat in the ischiorectal fossa, there is no support to the rectal mucosa and it will prolapse out. So the treatment is mainly digital repositioning. That's all. So reposition the prolapse, but in case it is not going to subside that easily, then you can inject submucosal phenol in almond oil, but this rarely we do it. So only repositioning, or sometimes there is what is called as banding. So there are Barron's bands. So Barron's bands. So Barron's bands are important and you can band them. There is a gun called as Barron's gun with which you will shoot these bands into the mucosa. So that is the treatment as far as children are concerned. Of course, in adults, usually hemorrhoids are the culprit. Along with hemorrhoids, prolapsed hemorrhoids, the mucosa of the rectum also will prolapse. mainly due to straining and sphincter weakness. So mainly for them, again, it is submucosal injection, that is phenol almond oil or bands. Sometimes what you can do is you can transfix and excise the distal portion. That also can be done, and sometimes rarely, if at all, stapling can also be done, but this simple excision is enough for adults. For children, it is repositioning or Barron's bands, whereas for adults, it is injection or bands, or rarely excision of the prolapsed mucosa. Okay. Now let us go to full thickness or complete rectal prolapse, also called as prosidentia. It is less common, mainly seen in women. That is, women are affected 6 times more often, mainly because of weak pelvic floor, because of deliveries. Nowadays, with this decreasing multiparity, even this can also be nowadays less common, and straining, because there is no opportune place or time for females to defecate. So they will be constipated and then straining. So that's why fissures are common, and with fissures, added pain is there, so there will be prolapse. So this complete means full thickness, that is all layers of the rectal wall. So actually it starts like interception, and same pathology holds good here also, interception. So the interceptum, intercepiens, all those things are here, there. So, and it should be more than 4 centimeters. Usually it is about 10 centimeters perhaps. So it is here, as you can imagine, it is double thickness. So what has come out is also should go in. So that's why it is the double thickness, the entire wall of rectum. So 2 layers are there, and in addition to rectum, walls of rectum, even peritoneum can come. So that is, if it is more than 5 centimeters, even pouch of peritoneum can also follow. Okay. So this is common in elderly, as I told you already, and in women. So this is the complete prolapse. You can see. So it is 2 layers, 2 complete layers of the rectum. So this is the inside one. About that, inside that is another layer. So this is the, that's why it is so thick. You can see it is the complete prolapse. So suppose you don't treat it, usually the patient will herself or himself will push it in, but sometimes they cannot, and it will just come out and then lead to rectal ulceration and even bleeding because of exposure, chronic exposure. There will be suffering with incontinence, and rarely what has come out may not go inside and can lead to strangulation very rarely. So, of course, naturally the differential diagnosis is interception, but you can see that the interception is mainly colon. So the colon is very thinner compared to rectum. That's why it will not be that much thick, even if it is containing 2 layers of the colon. Okay. So the investigations are not much except for fitness of the patient. So what is the treatment? Only surgery is the answer. And you can have 2 approaches. One is perineal, that is from outside you can treat it. Rarely you may have to open the abdomen. So abdominal. So now perineal, safest for elderly people because of their comorbid conditions. Usually we will try to treat it from outside. And also for men, young men, which may cause sexual dysfunction, because if you see these layers of the, see here, you can see beyond this Walder's fascia, these are the plexus. Just before the or anterior to the presacral fascia, there are plexus. These plexus are very, very important for potency and also the function of the bladder and the rectum. So if you damage them, the patient may have incontinence of not only bladder or rectum. In addition, they will also have the, so they will have also sexual dysfunction. So that is very important. So in young people and in elderly, we will prefer perineal approach. So what are the operations? We have three operations, that is tears operation for elderly, reserved for elderly. It's only simple wiring. So here you should also remember the other thing about tears. What is it? Other thing about tears? Should not forget the surgery subject. So tears is, I have given a question also about other tears. Yeah, good. 4-8. You are correct. It is tears graft, skin graft. Thin or split thickness. Split thickness. It is not full thickness, it is split thickness. Skin grafting is called as tears graft, whereas this is tears operation. I'll show you what it is. Then you have another bigger operation, that is Delorme's and Altimere's operations are there. So we can do either tears or Delorme's. Then abdominal, of course, it involves fixing the rectum in its original position, and it is called as rectopexy. So anything you fix it, it is called as rectopexy. So it can be, nowadays they are doing it as laparoscopic rectopexy, either simple fixing with thick suture material or with mesh. So both are available. So that is abdominal approach. So this is Thier's operation, wherein you can see two incisions are given both anteriorly and posteriorly. Through that, we will pass the thick suture material, usually either steel or thick proline, and then along the circumference of the anal canal and to certain extent inside and in depth. So both ends are brought together, and then you will introduce your index finger into the rectum and ask the assistant to tie it around the index finger. Otherwise, if you tie it more tightly, then even finger will not be passed and the patient cannot pass motion. So that's why it should be snugly tight, but not too tight or too loose. If it is too loose, through that opening it can again prolapse. So this is how, this is tight, snug fitting. So they have sutured it, and this is the result. So this is called as Thier's operation. Then you have another operation, that is Delorme's. So this is the prolapsed rectum. You will, just like degloving we call, you will remove this is the mucosa that is removed. That is from the muscularis, they have degloved the mucosa, and they have to cut this mucosa here and then pass these purse string sutures into the muscles of the prolapsed rectum like this, and then they will tighten it so that what is called as the concertina effect. So it will be like a spring, it will contract, and then once it is done, what they do is they will suture this mucosa to this mucosa, so that again the whole thing will go back inside and will not come out. So this is the Delorme's operation. Okay. So once again, the mucosa is removed from the prolapsed rectum, and the purse string sutures are passed, multiple purse string sutures around the prolapsed rectum into the muscularis, and they are tied snugly so that the whole thing will become short up to this, and then this mucosa is sutured to this mucosa. So that is the Delorme's operation. Then laparoscopic, of course, this is the mesh. After complete separation of the rectum and sigmoid, they'll put this mesh either anteriorly, here it is ventral, sometimes it is posteriorly to the sacrum. Either way, they will do it. So that the main aim is the dissected and separated rectum should not go back in down. So this is laparoscopic ventral rectopexy. Okay. Now we will go to the other lesion, that is proctitis. You might have already heard about ulcerative proctocolitis. So that will start in the rectum. Then you have Crohn's disease, which can affect the rectum, though it is mainly the colonic problem. Then due to radiation also, there may be proctitis. Then there are certain specific infections like Clostridium difficile, and then bacillary, amoebic dysentery, all of them you know. Peculiarly, even bilharziasis may be there, particularly in Egyptian countries. Tuberculosis of the rectum, very, very important. Anal canal and rectum tuberculosis, it will result in multiple fistula formation. So whenever there are multiple fistulae, you have to suspect anorectal tuberculosis. And in fact, it's a good habit for sending the fistulous tract for biopsy so that tuberculosis can be excluded. Non-healing fistula, about 15% to 20% of them are due to tuberculosis. Then of course, gonococcal, LGB, AIDS, cytomegalovirus, all these are there. And then there is what is called as a strawberry lesion, where there are due to these spirochetes, Spirocheta vincenti and Bacillus fusiformis. Just like oral cavity Vincent's angina, there may be what is called a strawberry lesion of the rectosigmoid. So then it is diagnosed by multiple pinpointing oozes of blood from the mucous membrane. So very characteristic of this strawberry lesion. Then in some places there may be herbal enemas they give, so that it can also, particularly Ayurvedic, they are not without danger, they can result in proctitis. So there are so many, most of them are to be treated with the way for general others. So just like ulcerative colitis, Crohn's, how they are treated. Same treatment for rectal disease also. And of course, for them, typical antibiotics have to be given. So then we will also discuss today, before we wind up, about the rectal polyps. This may be given as a short notes for you. So this is the most frequent site, rectum. That's why rectal polyps, most frequent site of polyps. So then we have varieties of polyps depending upon their macroscopic appearance or depending upon their histology. Macroscopic, they are pedunculated, sessile, and flat, whereas histology, tubular, villus, tubular villus. Can anybody tell me the significance of villus polyps or adenoma? In our days, entrance bit was given about villus adenoma. What's its significance? So, yeah. Yeah, that is one. Yes, 143. It is the one I'll tell you. Two problems with villus adenoma is one is it is highly having high malignant potential. Tubular is also having, but not, yeah, pre-malignant, correct? So the tubular is less malignant potential compared to villus. But if it is tubular villus, it is equally bad. But tubular, the villus is having another problem, that is, it will be secreting a lot of mucus which contains potassium. So there is electrolyte disturbance. So that is also important. So the other, just now I was telling, they can become malignant. Particularly those which are more than 1 centimeters, you should view with suspicion. Try to remove them as early as possible. Otherwise, they may lead to malignancy. So you have to remove and then send for biopsy to exclude already set in carcinoma. So how do we do it? It is mainly by endoscopy. Endoscopy, what they call as snare polypectomy. With a snare, they will remove it. But of course, if it is accessible perianally, even a surgeon can also remove them. So then another thing is sometimes, particularly for sessile and flat, you may have to resort to what is called as endoscopic mucosal resection. So you may have to do removal in a wider area, that is called as endoscopic mucosal resection. There is also another procedure called as transanal endoscopic microsurgery. So this is just like carcinoma sometimes, or other way around, like polyps, we can even do for carcinoma early stages this transanal endoscopic microsurgery. You have to remember these terms because you should know the recent advances. Okay, so transanal endoscopic microsurgery, this is nothing but inside the thing you will pass a laparoscope and then remove these tumors, even cancer also. Another important aspect is you should always do colonoscopy, because once there is one adenoma, you should exclude proximal polyps. Very, very important. So simultaneously, there may be multiple polyps. You have treated the one which is lowermost, but this is called as low hanging fruits you have removed, but inside you have forgotten or you have not bothered, you have neglected, and it can lead to carcinoma, colon. So you have to be very thorough and do colonoscopy to exclude other polyps. So this is in short this rectal polyps. And so already I told you about the tubular one, which is can turn malignancy into malignancy. This is the most common polyp, tubular variety. So villus is saffron-like, very large, occupying most of the rectum. So inside the rectum, it can occupy the area, and it has increased tendency, and it will discharge mucus, which is rich in potassium. And there are other types like hyperplastic, inflammatory. These are all also there, and conservative treatment, hyperplastic and inflammatory. Then you have another one that is called as familial adenomatous polyposis. So this in colon, you might have heard about this, lot of malignancy potential for that. So it is autosomal dominant, and it is mainly due to mutation in APC gene called as Adenomatous Polyposis coli gene, APC gene. So it starts around puberty, and multiple, even hundreds or thousands. So you have to do genetic testing, colonoscopy, and biopsy. And so if the person is having APC gene mutation, means it is highly desirable that we do total colectomy as early as possible. Just before 10 years, patient should be rid of colon, and then you have to, because it is also common in rectum, you have to be thorough about surveillance. Okay? Then juvenile polyp, this is nothing specific. So single, there is no malignant potential, whereas multiple, there is risk of malignancy. So this is also called as cherry tumor. In children, this is one of the cause for bleeding and pain. So that is called as juvenile polyp or cherry tumor, and it will usually get itself out, but sometimes you may have to remove it. Okay, so these are the things about polyps. So in the next class, we will discuss about the rectal carcinoma. Before that also, we will talk something about the benign rectal lesions also. So that is in short about the benign lesions of the rectum, the surgical anatomy and benign lesions of the rectum. So we will, in the next class, as I told you, we'll discuss a more important topic, that is carcinoma of the rectum, which is, though may not be for your theory, for your practice, it is very, very important, because you are the ones who are to send the patient with carcinoma early to the specialist for proper treatment and guidance. Okay, right. Now, if you have any doubts, you can ask me. And another thing is, from since that urology is complete, from Thursday, uh, we have to take up another program. Suggest to your representative who will contact me regarding Thursday's program, so that, because Monday we have another subject, that is topic, that will go on for 2 to 3 classes, that is pancreas, whereas Fridays we are now with bottom surgery, that is rectum. Later we'll go for anal canal. Ultimately, we'll finish off all these things. But Thursday is free. Monday, Tuesday, and Wednesday you have clinical discussion. Of course, this next Tuesday you will have exam. Later, we will continue with clinical discussions till your college is open. But Thursday, It is up to you. How do you want to utilize them? I am open for any suggestion. Now, if you don't have any doubts, we'll call it quits for today. Okay. Thank you.